Hello and welcome back, everybody, from our break, and to welcome you to our last educational session of day one. Our session currently is medical treatment of early stage disease, and we are welcomed by Dr. Salawu. Dr. Salawu specializes in the treatment of sarcoma, gastrointestinal cancer, and peritoneal malignancy. He is also a PI in the Phase 1 drug development program. He underwent specialty training in medical oncology in Sheffield, United Kingdom, and holds a master's and doctoral degrees from the University of Sheffield. His research expertise lies in structural and functional genomics, disease, disease models, and biomarker development. Dr. Salawu's current research focuses on translational oncology and early phase drug development, particularly using biomarkers to guide personalized cancer therapies. He's the recipient of the Novartis Oncology Young Canadian Investigator Award and the American Society of Clinical Oncology Merit and Young Investigators Awards. He is also an equity-focused clinical investigator with an interest in disparities and representation in oncology clinical research. We thank you so much, Dr. Salawu, for being here, and I'm happy to pass it to you.
Thank you so much for that kind introduction. I'm going to try and share my presentation. Okay, I hope that's coming across excellent. Okay, thanks for the introduction. My name is Aziz Salawu. Everyone calls me Aziz. And I've been asked to discuss the medical treatment of early stage disease in colorectal cancer. It's my utmost privilege to be involved in the management of this disease for many patients and to be given the opportunity to make this presentation today. Here are some disclosures. I received research support from a number of different pharmaceutical companies in my role as a drug development investigator, as well as some advisory roles. So I thought I'd start this talk by talking about what early stage disease means, or earlier stage disease. What do we mean by stage exactly? Well, tumor stage essentially just means what's the extent of a cancer. It's an academic subdivision. It's a way for academics to speak to one another and make sure that they're on the same page. And the way we've subdivided cancers is based on characteristics that have an impact on the expected outcomes. That's the prognosis of the cancers. And also, things that might have an impact on our approach to treatment. So we'll treat one stage in one way and another stage in a different way. So here I have a pictorial representation. Sorry. On the left side of what we call the T stage. So the T stage is the tumor stage of a primary colorectal cancer tumor. And when we stage it, the primary tumor, we stage it based on how many layers of this cylindrical organ called the bowel has the tumor penetrated. So what that means is that for a tumor that's only in the inner layer of the bowel, it's called a T1, where it's spread a little bit more to involve the muscle layer. That's called a T2. If it goes beyond that, spreading beyond that muscle layer, is called a T3 into the outer lining. And when it's crossed all the walls and actually spread, outside the boundary of that bowel, it's called a T4. Quite often in this stage, it's starting to invade some nearby structures. We also have what we call the kind of number staging, where we group, tumors of certain kinds into stages. The most important thing to know about bowel cancer is that if you have something that's stage 1, it's only in the inner layer. If it's stage 2, it's in the muscle layer. Stage 3 means that it has spread from the bowel itself to lymph nodes in the area. And lymph nodes are glands along these channels called lymphatics that drain excess fluid from the different organs of the body. So when there's lymph nodes involved, and we know that that's usually the first port of call for a cancer to spread, we call that a stage 3. And when it's spread beyond those lymph nodes to distant organs, we call that stage 4. So I hope that explanation of what stage means is clear. Now, when we talk about early stage disease, we're referring to these first three stages, stages 1, 2, and 3, not stage 4. Stage 4 is not regarded as early stage disease, it's regarded as later stage disease. Now, when we say that stage has an impact on outcomes or prognosis, what do we mean? If you look at this graph here, stage 1 is the green line, and patients who had stage 1 cancers, colorectal cancers, who had standard treatment, 98.6% of them were alive at 5 years. So that's a good prognosis. When you extend that to the yellow line, which is stage 2, you find that that number drops by about 10% to 88.6%. If you move on to those who had stage 3 cancer, so remember that's where there's lymph nodes involved, that number with the current standard of care treatment comes down to about 71%. So we're talking about roughly 3 in 4 patients get cured versus almost every patient with stage 1 disease. And if you move this to the stage 4 disease, which is not early stage cancer, which is a later stage cancer, that number at 5 years drops to only about 13%. So stage matters in terms of prognosis, in terms of what to expect. So that's the importance of staging. How does this impact on our treatment? In general, for early stage disease, so this is stage 1, 2, and 3, the primary goal of treatment is to cure the disease, take that disease away completely. If you look at the previous slide, patients with stages 1, 2, and 3 disease had, at least 70% chance of a cure from their treatment. Stage 4 is a different ballgame. So, for stage 1, 2, and 3 disease, we are aiming to cure patients, make sure that they are alive and well in 5 years or even beyond that. And what we mean by a cure is that we want to remove or destroy all the cancer cells that's available so that the patient remains cancer-free and the disease does not come back for as long as possible. Quite often, the main way to achieve this is surgery. So surgery is the mainstay of treatment for this early stage disease with the view of achieving the cure. And for that surgery to be adequate, we have to remove all visible disease. And often this is with what we call negative margins, which means that the tumor is removed with a margin of healthy tissue around it. And our pathologists are able to look at the edges of the healthy tissue to see if there's any microscopic cancer cells that may have been left behind. For colon cancers, sometimes we have to remove a part of the disease. So remove a part of the bowel that's affected and join the rest of the bowel together. So you hear about things like hemicolectomies, etc., from my surgical colleagues. I will stop there so that I'm not speaking out of turn. I'm only a chemo guy after all. Now, in addition to surgery, sometimes we require other treatments, to kill or eliminate any cancer cells that may be left behind after surgery. This is not to say our surgeons are not excellent, but sometimes there's only so much that they can do because they can only operate on the primary site of disease. And we know that cancers have that ability to spread, and there may be small cells around in the body that you just can't see at surgery. So you might sometimes require other treatments to kill or remove any of those cells that may be left behind. And this way we lower the chances of the cancer returning after the treatment is completed. This usually takes one of two forms. You can either have a systemic therapy, which is a body-wide therapy like chemotherapy that goes all over the body, or you can have a more localized therapy that's focusing on a particular area of the body, such as radiotherapy. And I'll go into this in a little bit more detail. So let's focus on systemic treatment first. So systemic treatment is a treatment that's given usually either by mouth or intravenously, and it spreads after absorption throughout the body, typically via the bloodstream. And it works to eliminate any cancer cells that can be, including any cancer cells that's left behind including those that cannot be seen on scans because they're too microscopic or too small. The whole point of this is to prevent the return of disease. And in giving chemotherapy, it's important that we balance this with quality of life. So that means that we need to give enough of the systemic treatment to achieve the goal of eradicating any disease that's left behind. But we also want to limit the side effects. We can subdivide medical treatments or systemic treatments into A, chemotherapy, which is drugs that typically kill fast-growing cells, like cancer cells. So cancer cells are fast-growing, and that's how chemotherapy is able to kill them. People talk about how chemotherapy kills the body cells as well. I wouldn't describe it that way. I think chemotherapy can slow down some of the body cells. The body's normal cells are able to recover, but the cancer cells are not. And that's the differential kill that we see with chemotherapy. Apart from chemotherapy, you also have targeted therapies, which are drugs that target specific abnormal molecules on cancer cells. We do not currently use a lot of targeted therapies in early stage colorectal cancer. It's used in some other settings, but it's important to mention them because they are a form of systemic treatment that we use. The final one, and probably the newest on the block, is immunotherapy, which are treatments that actually boost the body's own immune system to recognize and kill cancer cells. Most of these immunotherapies are given intravenously, but at this point, they're only given to a select kind of people with a select kind of colorectal cancer. And again, I will talk about that in a little bit. So I've talked about the fact that we can use surgery, we can use radiotherapy, we can use chemotherapy, we can use targeted therapy, immunotherapy. How do we make the decisions for what to use? This is where multidisciplinary care is important. It's important that we have all the experts at the table to decide what's the best path forward to get the best outcome for any individual patients we're seeing. And that treatment must be personalized to that individual and what their goals are. So here's the concept of what we call a shared decision making. It's not for the clinician or oncologist to tell a patient what to do. It's for that clinician to make sure that the patient understands their options vis-a-vis what they want for themselves. And then together you can make the decision about what's the best path forward to achieve the goals that you both have. Important factors to consider when we make these decisions are the tumor stage, because as I've said, the stage of the tumor has an impact on the expected outcome of the disease and also has an impact on what we can do about the disease. What's the best treatment for it? It also depends on what we call biomarkers, which are things that you can measure in the body, whether that be on the tumor cells or in the bloodstream or other ways, that can give you information about how to treat the patient or what the diagnosis is or how the patient is, what the expected outcomes could be. Also, you should think about the goals of treatment. Not everyone wants the same thing, and it's important to know what those goals are. And fed into these goals are what's the overall benefit of any treatment plan that one is putting forward versus the risk of side effects. So, it's kind of intuitive to think that, well, if a disease is curable, surely everyone would want a cure for their cancer. But if you do this long enough, you know that, not everyone wants to go through what it takes to achieve that cure, or want to live life after what it requires to have that cure. And so it's important to actually listen to the patients and make sure that you share the goals with them, and not make assumptions on their behalf. Now, we're going back to systemic treatment because that's what we're talking about. I use systemic and medical treatments kind of interchangeably here. And the timing of systemic treatment matters. You can use systemic treatment before surgery. As I've mentioned, surgery is the mainstay of curing colorectal cancers. But you can use systemic treatments before surgery. And this is what we call the neoadjuvant setting. Here, the treatment is given prior to the surgery with the goal of shrinking the tumor, killing any cancer cells, early on, to make the surgery more effective. So by going all over the body to kill any cancer cells, first you're eradicating any tiny cells that you may not have been able to see on your scans, whether that be a CT scan or other kind of scan. But secondly, you might be able to shrink the tumor and make the surgery easier, among other things. We most often use neoadjuvant treatment when we treat rectal cancers, because we have a lot more data for it in terms of clinical trials. And the rectal cancers are located in a pretty small space. So it's not uncommon for it to be desirable to shrink the tumor down a little bit to make surgery easier and make that achievement of what we call negative margins more realistic. Sometimes we'll use neoadjuvant treatment for colon cancers. Again, this is often with very large tumors, where surgery is likely to be more successful if we can shrink them down. We could also use medical therapies after surgery, and this is what we call adjuvant treatment. The goal here is to mop up any remaining cancer cells that surgery could not see. And we most often use this kind of treatment in patients where, following the surgery, the tumor gets sent to the lab and they look at all the lymph nodes in the area, which are really typically removed at the time of surgery. If there's any positive lymph nodes, which means that the pathologist can see tumor cells within the lymph nodes, then this is classed as a stage 3 cancer. And this is where the most benefit of systemic therapy is found. In fact, the data suggests that if you have a colorectal cancer that has spread to lymph nodes, with surgery alone, you have about a 40% of curing that cancer. But if you follow that surgery with chemotherapy, your chances of curing that cancer move to about 70 to 80%, which is almost double. So in patients who have positive lymph nodes or stage 3 colorectal cancer, the benefit of systemic treatment in the adjuvant setting after surgery is high. However, you can have some patients with stage 2 cancers where there's no lymph node involvement, but there's other factors, which I will call biomarkers. Other factors, typically pathological factors, that the pathologist can see that make this a high-risk cancer. And in such patients, we also consider using adjuvant medical treatment. Now, the most common treatment we use in this setting, whether it's neoadjuvant or adjuvant, is chemotherapy. It's the backbone of the medical treatments that we use in early-stage bowel cancers. It's been proven to reduce the chances of the cancer returning in stage 3 disease, as I've explained. And the most common drugs that we use are a drug called 5-FU or 5-fluorouracil, another drug which is actually in pill form called capecitabine or Xeloda. And these drugs are the backbone, and they're often combined with another drug called oxaliplatin. If you combine oxaliplatin with intravenous 5-fluorouracil, the regimen is typically called 4-FOX. If you combine it with the pills, capecitabine is frequently called Capox or Xelox. The administration of the 5-fluorouracil is via a continuous infusion pump, and the oxaliplatin is also intravenous, but just as a drip. And the capecitabine is typically given orally. Whether it's the neoadjuvant setting or in the adjuvant setting for an early stage bowel cancer, the duration of treatment is about 3 months. The treatments are given every 2 weeks or every 3 weeks, depending on which regimen you choose. But the total duration of treatment is somewhere between 3 and 6 months as the current standard of care. Immunotherapy, in its current form, is a class of drugs that we call immune checkpoint inhibitors. And the way they work is by inhibiting the checkpoints in the immune system. So the immune system has a way of starting and stopping. If you run into a bug or some other irritant, your immune system wakes up to deal with it. And once that threat is gone, the immune system puts on the brakes and shuts itself off. We know that cancers are sometimes able to evade the immune system by actually, tricking the immune system into putting on these brakes. And what these drugs do is they take these brakes off the immune system and allow the immune system to do its job of killing the cancer cells. For colorectal cancers, the subset of tumors that actually have been shown to exhibit this trait of being able to trick the immune system and hiding themselves from the immune system are what we call MSI high tumors or MMR deficient tumors. MMR means mismatch repair, MSI means microsatellite instability. But they are a very, very important tool for us to decide what treatment works. And this is because if you have a tumor that is MSI high or MMR deficient, immunotherapy has a very high chance of working. And this was well demonstrated by a study in young patients who had early stage rectal cancers who were given immunotherapy only for a few months. And in all of them, there were 16 in the initial set, but there's way more now. I think there's more than 40 or 50 now, where in all of them, the tumors disappeared completely without the need for surgery and have remained so for years. So immunotherapy really works in that kind of disease. If, however, the tumor is not MSI high and there's a pathologic test for this, then the tumors really do not respond to the current form of immunotherapy with checkpoint inhibitors, and we do not use immunotherapy for that. On the contrary, we use chemotherapy. And, the reverse works because those tumors that are MSI high have also been shown to not really benefit very much from chemotherapy. So as an oncologist, it's very important for me to see this biomarker, MSI high, to know whether I'm going to treat the patient with immunotherapy or with chemotherapy. It's important to note, however, that in Canada, as things stand right now, for early stage disease, we do not have ready access to immunotherapy, but it is something that we discuss. Sometimes we have clinical trials that we can put patients on as required. The clinical trials are still going on to help us establish how exactly to use it in routine care. Fortunately, MSI high tumors are a small subset, only 10 to 15% of early stage cancers. Now, there's a concept called total neoadjuvant treatment, which is where we give chemotherapy and radiotherapy to patients before possible surgery. And this has been established in early rectal cancers, not colon, but rectal cancers. And it's based on a number of studies. I think probably the most important of them is what we call the OPRA trial, which was a trial that was looking to see whether giving this chemotherapy and radiotherapy could actually cancel the need to have surgery. So what we call organ preservation, where the tumor does not have to be, the organ, which is here in this case, the rectum, does not have to be removed. This is very attractive to certain patients because some patients will have to have a permanent ostomy after their surgery or things like that. And that has a profound impact on their quality of life after treatment. And being able to live with the rectum prevents that need. I won't go into a lot of detail, but just to say that the OPRA trial has shown us that we have about a 30% chance of achieving this goal of complete tumor cell kill by giving chemotherapy and radiotherapy before assessing for surgery. And in patients where the tumor disappears completely, we can safely watch them very closely over time. We know that about half of them may recur. And at recurrence, we can then do surgery because it's needed. And the outcomes are the same whether we do surgery as a planned thing upfront versus if we do surgery when they recur. So this is a strategy that we are adopting more and more. It's important that this is done in institutions that have the capacity to watch patients closely so that they don't miss that window of if the disease comes back. The last part of my talk is going to be about what we call biomarkers. These are things that you can measure in treatments. They're essentially additional tests beyond saying that this is a colorectal cancer. We've talked extensively about what we call MSI high and how it helps oncologists to decide whether the patient needs chemotherapy versus immunotherapy. We also do gene testing for mutations in a number of genes. The first group has been around for quite a while now, maybe 20 odd years, maybe a bit longer, and that is the KRAS and other RAS mutations, as well as BRAF mutations. In the early colorectal cancer space, so for early stage disease, stage 1 to 3, those mutations don't really impact what we do. However, in later stage disease, they have an important impact on what we do. And so we do this testing more and more in the early stage disease because there's another gene, which is called PIK3CA, where the mutations have been found to have a bit more importance. And we're looking at this a lot more in practice now. On the right side is a pie chart just to show the distribution of certain KRAS mutations. I like the chart because it's colorful. It's not, I don't really need to discuss the content of that chart today, because as I said, it shows you some of the different mutations we have in colorectal cancer, but those don't really have much impact on early stage disease. Some of them may have some impact on the expected outcomes of disease and how disease behaves, but it doesn't really change how we treat the disease, because every patient needs to go on surveillance after they've had this curative treatment for the early stage disease. The last one is something called ctDNA, which is small bits of tumor DNA that you can pick up in the bloodstream. And it's something that I will talk about because it's a very commonly recurring question, because the technology is way ahead of the clinical utility. And I'll talk about it in a little bit. Try to shed some light on what studies we have so far to help guide us in the clinic, but more importantly, emphasize that we don't have all the answers yet, but we're working hard to get those answers. So I'm going to go back to the PIK3CA mutations first. And there was a study that was presented last year at the ASCO GI meeting. And it's a study called Alaska. It has nothing to do with that part of the United States. But it's a study that looked at the role of low-dose aspirin, your baby aspirins, 2 pills a day, in patients who have colorectal cancers. Essentially, what the investigators did is that they screened 3,500 patients for mutations in this gene called PIK3CA and some related genes. So they didn't only look for mutations in that PIK3CA gene. They also looked at some related genes like PIK3R1, P10, etc. And they subgrouped patients into those who had PIK3CA mutations, as well as those who had mutations in the related genes, but not PIK3CA itself, or the more common culprits in terms of mutations of PIK3CA. And for both those groups, they gave half of them aspirin, 160 milligrams, 2 baby aspirins every day for 3 years. And the other group had placebo, a sugar pill, daily for 3 years. They did that for both groups of patients. And they looked at the chances of the disease coming back in terms of how long it took before the disease came back and what the overall disease-free survival was in these groups. The key takeaways was that the aspirin was able to reduce the recurrence rate, the proportion of patients who had recurrence of their colorectal cancer, by about 50%. So about half the proportion of patients who had aspirin had their disease come back when they had these mutations. And it didn't matter which group they were in, whether they had mutations in PIK3CA itself or in the related genes. Considering that, about a third of patients can possibly have these mutations, and that the drug is very cheap. It's a very easy intervention to do to try and reduce the risk of our patients getting their cancer coming back. We typically do this after patients have had chemotherapy, if they need chemotherapy, because in the Alaska trial, those patients did have their chemotherapy. So it's not a replacement for chemotherapy as much as we wish it was. Aspirin has been around for a long time. Many people take aspirin. It's not very dangerous. It has a small risk of bleeding, which physicians are able to monitor for or advise, whether it's too dangerous to go ahead. And the key barrier or bottleneck that we can have to using aspirin in our patients is whether that genetic testing for the PIK3CA mutation actually happens. It's relatively new data. It's something that we're still contending with, and we have a huge public health system that is working its way around how exactly we implement doing this testing for a group of patients where we didn't typically do this kind of testing. So right now, in most centers, oncologists are able to request it. And it's something that is worthwhile asking your physician about if you're a patient or advising a patient. The other test that I will talk about, and this is my last slide, you'll be happy to hear, is circulating tumor DNA. So we talked about traditional staging of cancers, where we do CT scans to look at, where the disease is, and we can typically see that on the scan. With circulating tumor DNA, all we do is we take a blood sample. And in that blood sample, what we know is that if there's tumor around, it can release small little bits of DNA as a cell cycle and they die off, which it is possible to detect with modern technology. We've known this for quite a long time now. I would say, upwards of 15, 20 years, there's been technology to detect this kind of DNA. And the technology has continued to improve. So we're able to detect smaller and smaller amounts of this DNA. The big question is, how does it change what we do in clinic? So I've already outlined to you what we do in clinic, which is we diagnose a patient, we do the staging to see what the extent of the disease is. We have a multidisciplinary decision and we speak to the patient to decide on the best way to go forward. Most patients who have early stage disease have surgery. And then depending on whether they have lymph node involvement or other high-risk features, they could have, chemotherapy afterwards. Some patients with rectal cancers have radiation and chemotherapy before they have surgery. But where does ctDNA come in? We don't know yet. So in order to try and answer these questions, a number of trials were done, and I'm going to highlight two of them. One was the dynamic trial. That's the one on the left side of your screen. And the other one is a follow-up trial called the dynamic 3 trial. It's a good thing I described what stage 2 cancer is and what stage 3 cancer is, because the dynamic trial was done in stage 2 cancers. And this is patients who did not have lymph node involvement, but for whom these high-risk features that make an oncologist think about giving chemotherapy after surgery were present. And what they did was they divided the patients into two. So one group, the oncologists used our standard, what we currently use as our standard decision-making tools to decide whether the patient was high risk and needed chemotherapy. The other group only got chemotherapy if they had a positive blood test for ctDNA. And this was in a window of about 3 months from their surgery. The patients had chemotherapy, based on this decision-making. And what the investigators found was that for those who we use our standard decision-making tools, about 30% of those patients went on to have chemotherapy based on the standard decision-making. When the decision-making was based on whether they had a positive ctDNA test, only 15% of patients, so half the proportion of patients, ended up having chemotherapy based on the ctDNA testing. And if you look at the outcomes in terms of the likelihood of the cancer coming back in both groups, it was exactly the same. So what that implies is that if you have a ctDNA negative test and you have a stage 2 cancer, it is very reasonable for you to skip chemotherapy because the outcomes are the same, right? And if we used our standard decision-making tools without ctDNA, we might offer chemotherapy to such a patient. So that was regarded as a positive trial. Remember, it's stage 2 disease, and remember, in stage 2 disease, over 90% of patients get a cure. And whether we use ctDNA or standard decision making, we still achieve this, 93%, 94% 5-year survival rate, which is excellent. Now we move on to the right side of your screen, which is a dynamic 3 trial. So this was looking at patients who had stage 3 cancers where the lymph nodes were involved. And the strategy that was used in this trial was to say, right, remember, it's a stage 3 cancer. Every oncologist on the planet will be nervous about not giving chemotherapy. Because as I told you, in a stage 3 cancer, chemotherapy improves your cure rate from about 40% to about 70 to 80%. So in this trial, what they did was they said, right, if you have a stage 3 cancer and your ctDNA test is negative, remember, this test is done within 3 months of your surgery, they could de-escalate your chemotherapy. So use a slightly lesser chemotherapy, less risk of side effects. What that means is that if we're going to give 5-FU and oxaliplatin, you would consider giving 5-FU alone. If you're going to do 6 months of treatment, you could consider doing 3 months of treatment, right? Based on the fact that the ctDNA is negative. Now, in another arm of the trial, if the ctDNA was positive, you escalated the treatment. You gave a slightly higher chemotherapy, which meant that if you were going to do 3 months of treatment, maybe you do 6 months of treatment, something along those lines. And what they found was that when they de-escalated the care, the outcomes were close, but not exactly the same. So if you look at those 2 bars there, I don't know if you can see my cursor. If you look at those 2 bars there, with the standard care, standard decision-making, which is what I said in all my initial slides, the outcomes were 88% were recurrence-free at 3 years, which is a good outcome. It aligns with all our previous studies. So, that gives the study some credibility. If you use ctDNA to decide and de-escalate treatments, you got an 85%, which is close to 88%, but it's not exactly the same. There's some fancy statistics done in there to see whether it is, non-inferior, etc., that show that it didn't quite meet the threshold for non-inferiority. And so it's not something that we can currently recommend. Okay. Now, if you go on to the other groups, what we found was that escalating the chemotherapy because someone had a positive ctDNA did not make any change. It did not improve their outcomes whatsoever. So again, we do not recommend escalating the treatment based on a ctDNA test. It's important to note that these 2 trials were done using the same ctDNA test, but that is just one among possibly 50 different ctDNA tests that exist in the world right now. Okay? And every ctDNA test is slightly different. It approaches the problem of detecting ctDNA slightly differently. So until we have data to guide us on how we use specific ctDNA tests, the jury remains out on ctDNA tests. For patients who are eligible, we try and enroll them in clinical trials. Canada has put itself on the map and done big trials for ctDNA and where its role will be in colorectal cancer. And we continue to work on that. And with that, thank you for listening to my talk. I'm more than happy to answer any questions.
Thank you so much, Dr. Salawu. We appreciate it so much. The session was so informative. And we thank you again for joining us today. Coaches will now actually move into their final question period of the day with Dr. Salawu, and both myself and Cassandra will stay on live to conclude today's agenda, albeit a slight bit early. So we encourage our coaches to head back to the backstage, and I will share my screen now.
Thank you for having me.
Okay, everyone. Thank you again. We appreciate you being here so much. As always, we like to leave our days with a quotation. In this case, it is coming from the perspective of a patient or a caregiver. I didn't want to upset my loved ones, but I couldn't carry this alone. And this is such a powerful message that really shares what so many patients feel during their journey. There's this feeling of guilt that gets passed on when they're looking for support. And what we recognize is that oftentimes, your family unit isn't enough. It's helpful, but it's nice to have a rounded support system. So having the supports of things like peer-to-peer programs like the My Colorectal Cancer Coach program go a long way in helping to fill some of those critical care gaps. Nobody ultimately should walk this journey alone, and our goal at CRAN is to try to support everyone walking this journey the best that we can. I'm happy to now pass it over to Cassandra McCauley, CRAN's Chief Research Officer, for our closing.
Thank you so much, Christopher. So again, my name is Cassandra McCauley. I am the Chief Research Officer here at CRAN, and it is my honor to be providing some closing remarks on behalf of Philomena, our President and CEO today. So I'll just start by sending out our gratitude to the summit sponsors, so Masters Insurance, Natera, Pfizer, and Taiho. Certainly without their support, we are not able to execute events such as these. So a great big thank you to our event sponsors. And what a wonderful day it's been. We have explored the basics of colorectal cancer. We've examined screening guidelines in Canada, talked about the prospects of a preventative cancer vaccine for Lynch syndrome. We talked about how primary cancer, colorectal cancer, is managed radiotherapeutically, and helped to make some sense of colorectal cancer genetics, a very complex topic. The day has ended with a session on the medical treatment of earlier stage disease, something that is very highly sought after. We are setting the stage for the balance of the expert-led sessions to come, and I truly hope that you found today's programming to be informative and to be helpful. I really do hope that you turn in tomorrow as we take a deeper dive into the surgical management of colorectal cancer, which includes ostomy care, as well as the surgical management of colorectal lung metastases, which will be speaking to the ever popular IVLP, the in vivo lung perfusion trial. We'll also talk about how coping strategies and sexual health and wellness can be incorporated into a patient's treatment plan. CRAN's registered dietitian will be joining us tomorrow morning as well to speak to nutritional recommendations for optimizing your treatment. So please stay tuned for an email in the morning tomorrow, which will contain 2 separate links. So there will be one link to log in for the morning sessions, and then a second access link for the afternoon. I'll just say thank you to our dedicated cancer coaches, our insightful expert speakers, and the broader colorectal cancer community who has been tuning in from home today. For now, I wish you a lovely, lovely evening, and I hope to see you all bright and early tomorrow morning as we carry on with day 2 of the My Colorectal Cancer Summit. Thank you.